And we are with Dr. Tim McKnight this morning, as we appreciate you coming in, as always. And, gosh, I'm going to get a little, I don't know, what would we call that, a tutorial on how to be a hospital patient? Is that
there's
fair?
a lot of things you need to know, I think, either a family member or as the patient, to understand the process of hospitals, what happens, and maybe some pointers as to what you can do as a patient or a family member to make your stay not more enjoyable, but more productive, and to be more satisfied with the experience.
Yeah.
There's a lot of things, when you become a patient and you're on that end of it, you think, boy, I feel forgotten, or why aren't they doing this or this? And I think it's important just to walk through the process to help people. So let's say you go to the hospital because you've got a fever and a cough, and you check in at the registration, and the first thing that will happen is someone at registration is going to triage you. They're going to say, are you urgent? Are you more important than the person just came in with chest pain, sweating, and looking like they're going to pass out, or can we put you in the waiting room for a while? So that's the first thing, is there's a hierarchy of who's the most critical. So we put the most critical patients back first. If you come in by squad, you're probably going right back to the emergency room. And then, of course, when you finally get back, sometimes there's a long wait time, and you're sitting, and the nurse comes in and gets your vital signs, and some things happen. And you may be down there for 4 or 5, sometimes 6, 7 hours. And what's happening is we're doing testing. We're getting a CAT scan. And we don't like what we see, so we need another image. But we're waiting for a radiologist who's reading this, maybe in California or an offsite, to give us the official read. Many of us can look at an x-ray and have a pretty good feel, but we don't want to make that final judgment unless it's a critical emergency where we have to make a snap decision.
Because that is not your specialty.
It's not our specialty. It's not something that we do. And if we make the wrong decision based on we're not as experienced as a radiologist, that could be critical. So we really like to have those reads. If it's a broken bone and it's simple, we don't need the radiologist. But most of the time we want that final read. And then there's the blood work. We have to get the blood work. We're waiting for results. And you're thinking, well, okay, this was all done an hour ago, and they told me we were almost done. But then the squad comes in with somebody having a heart attack or somebody in a cardiopulmonary arrest, and the doctor has to run to take care of this. Or the nurse has to go take care of somebody who's starting to throw up. So you really can't, you never really know what's happening behind the scenes. You might be sitting in that emergency room bay and looking out at the nurses station and seeing the nurses and the doctors stand around talking or laughing or acting like they're not in any hurry, when really they're waiting and they're prioritizing. So that's hard even for me as a patient to think, why is this taking so long? But being on the other side of that, you see that we really are. Our goal is to get people in and out as fast as we can, make the right diagnosis. So let's say you're admitted to the hospital. You have a pneumonia. You have to come into the hospital. Well, in the emergency room, you're probably going to have an IV started. You may be put on some oxygen. In certain conditions, certain people, they're going to put a catheter in you. They may or may not. You may or may not have a nasogastric tube put in your stomach if you're throwing up. Those aren't comfortable. You'll have maybe a monitor put on your heart to watch that, some stickers with wires. So you go upstairs maybe to the floor, and you're all wired up and hooked up to things, but it's all part of the monitoring process.
So I already have my gown on at this point, because that's semi-traumatic also.
It's really traumatic. Yeah, you're essentially naked with a thin sheet over you, right? And you're vulnerable to everybody. You get up to go to the bathroom, and the backside is open, and everybody's got a free shot of the backside. So, yeah, that's not comfortable for anybody. When you get up to the floor, that typically the nurses taking care of you will come up and get all of your information. And you'll repeat all the same answers you gave to the doctors and nurses downstairs. They want to hear it again. Before you come up, though, the nurse in the emergency room will say, hey, we've got this patient with pneumonia coming in. This is their history. These are some things that we found. So the nurse is already aware of some of the situation, but has to chart all this. And now everything is electronic. So this is computer generated, computer entered. And so once we get all that information, that usually takes about an hour to do that assessment for the nurses. And they're very thorough. They make sure you don't have a bed sore, and they look at everything. And they do a complete assessment. Then they have to contact the doctor, and the doctor has to put orders in. Now, usually what happens on my end as a hospitalist, the emergency room doctor will say, hey, I've got so-and-so here. this is the x-ray, these are the labs, I'm recommending we admit this patient. And if I feel comfortable that that patient is safe and that we can take care of their needs at our facility, we'll say sure. If they're complicated and we're worried that maybe other things will arise, we recommend transferring to another facility. So there's a lot of thought process going on the other end before you get up to the medical floor to be taken care of. But then we have to put orders in. You might be having some pain, and you told the nurse, hey, I got some pain medicine 3 hours ago. It's coming back. Well, the emergency room doctor, once you leave the emergency room, they're no longer responsible for you. Now it's the provider on the other end of the hospital. So we have to get those orders in. And that takes a little while. That's also electronic, and it takes a little while. So once you're admitted, a couple things to know is that when the nurses usually change shift, it's usually 7 in the morning. So about 6:30, 6 o'clock, it's usually relatively quiet on the nurses' floor. That's a profane word to say in the hospital.
Yeah,
it's quiet, right? But it is usually pretty calm. Now, 5 o'clock a.m. is usually, sometimes 4 o'clock in some facilities, that's when they draw blood. So you're fast asleep and somebody's poking your arm for blood. Well, we usually want all those blood tests back by 7 o'clock, sometimes 6 o'clock in the morning, because doctors are doing rounds. They need that information. So it's not the most convenient time for patients, but we're trying to get moving for the day. So 7 o'clock is the checkout. So at 7 o'clock, the nurses coming in for the day are there, and they are usually sitting down with the nurses who are leaving, and it's a one-on-one checkout. I've got 7 patients. Let me tell you about these 7. These are the things we're doing and worrying about. And that can take a while. Mm-hmm. And then once that's done, usually it takes about an hour, depending on the volume. Then the nurses are like, okay, it's time to get those medications. So they're going to the Pyxis where everything's locked up, and they're getting medications, and they're passing the medications for an hour, maybe an hour and a half, 2 hours. So it's 9 o'clock now and 10 o'clock, and the nurses have finally kind of slowed down unless another admission comes in. So they're really busy people. And let me just say, nurses are some of the most compassionate, loving, kind people you ever meet. But when they have been stressed, they're like the rest of us. Maybe they can be a little snappy or a little frustrated. So we have to really just be gentle and kind with them as patients or family members. There's a right time to talk to a nurse on the phone as a family man. There's a wrong time. And the wrong time is between 7 and 9 o'clock. They're extremely busy, or you can call them, say, can you call me back when you've got some time to talk? Because often they give us a lot of good information. Mm-hmm. And sometimes as a family member, you want to talk to the doctor. Well, that's fine, but the nurses are sometimes even better to talk to than the doctor.
More up to the minute.
They're up to the minute, and they can say, hey, I came in at 7, she looked like this, it's 1 o'clock, I've seen this change, or they're better. The doctors are in and out in a few minutes, and they don't know them at that level. They're not picking up those little cues that things are changing for the better or the worse. And the nurses, they know what's going on. They might not be able to answer all the questions, but they usually know the plan. Yeah. So when we come in and round in the morning as physicians, we have a time at our hospital at 9:30 where we sit down with the whole team and we go over every patient. And so the team includes the hospitalist, the nurses involved, a discharge planner, a social worker, and the pharmacist. And I'll ask the pharmacist, hey, what do you think about adding this medication, changing this? Do you see any issues with this? So the pharmacist chimes in. This person's ready to go home. Do we have everything set up? Do we have therapy set up, home health set up? What are their needs? When is their ride coming? And so this is a great conversation as we go through this. So we're all on the same page before late morning. We know what's happening. And I think that's also really important for people to know. Something else to know is that often we will ask patients when they come in the emergency room or when they come up to the floor, what's your code status? And in other words, what do you have a living will? What do we do if the heart stops or you have problems breathing? most people that are healthy we call them full arrest. We do everything. And if it leads to a ventilator, let's put them on a ventilator. And those are usually healthy people that are out and around, and they got a fighting chance to survive something like that. The other extreme is someone who's in the terminal stages of cancer or emphysema or heart failure. They're just kind of done fighting. And those do not resuscitate comfort care. So when they come in, we're going to keep them comfortable. We'll treat their infection, but we're not going to do it any heroic medication kind of measures other than controlling their nausea, controlling their pain, controlling their anxiety. And sometimes we'll get hospice involved. The real tricky one is the one in between that do not resuscitate arrest. So what that means is if we see the heart is going to stop or your breathing is going to stop, we'll do everything we can with medications, but we're not putting hands on you. We're not doing chest compressions. We're not shocking your heart. We're not sticking a tube in your throat, putting you on a ventilator. Who would that apply to? Those are people that have a lot of comorbidities. They've had a lot of health problems, and putting them on a ventilator is not likely to end up well for them because they could live for months, and then who's going to decide how long they stay? Mm-hmm. Mom says a week. Son out of town says no. We're going to pray, and we're gonna have faith that they're going to heal. And it's 3 weeks later, and the patient is probably not going to recover, but the family is now at odds. So those are the things family members need to talk about early and make sure they're on the same page. And you can talk to nurses about this. You can talk to the doctors who say, we normally don't see these people surviving. You don't want to. We try to guide people, but everybody has to make their own decision, right? And that's a tough one. So that's a lot of forethought, a lot of conversation.
That is. That's something that you need to take care of. All right. Quickly now, I have gotten better, and I'm ready to go.
Yes.
So what's that look like?
That looks like we talk about that in morning rounds. Okay. So Brad's ready to go home. Does he have everything he needs? As a provider, I've got to make sure that your medication, we're going to give you a medication list, and we're going to say, I want you to stop these 3. These are 2 new ones. This is an antibiotic. I just sent it in electronically to the pharmacy. You can have a family member pick it up in an hour. We've got home health arranged. They're going to come and check your wounds. We got therapy coming twice a week. They'll be calling you. We'll set that all up. The doctors then have to write the discharge order, so you can't leave until that's done. And then the nurses come in and they bring you an information packet. This is what you came in with. This is what we're doing. Here's your the new list of medications. Do you have any questions? We're going to arrange for your follow-up with your providers, your doctors. You're going to see your family doctor on this date, your cardiologist on this date. We want you to get labs on this date or an x-ray. So all that's taken care of. Take the IVs out. We disconnect all the tubes and the monitors. And it's kind of funny, sometimes by this point you feel great. Hey, I'm ready to go. Mm-hmm. And we wheel you out in a wheelchair.
Right.
You take your gown off, you put street clothes on, and you're so excited to go, but we wheel you out. We don't want you
to the door.
We don't want you passing out. Yeah. That's bad form. So all those things have to happen for you to be discharged and get out of the hospital. So there, like I said, there's a lot involved, and there's some things that in the hospital every patient should do, or every family member should say, hey, are we doing this? And number one is get up out of bed. If you lay in bed, you're going to get weaker. And if you're already weak, you might have difficulty walking after 3 or 4 days in the hospital. Yeah. So I will often say, hey, I want this person to walk twice a day in the halls with assistance. Don't want them to fall. I need a nurse or a nurse's aide to walk with them. If they're weaker, we want physical therapy there. We'll do a physical therapy evaluation. Can this person safely get out of bed and get to the bathroom? Are they ready to go home without us worrying about a fall or an injury? So they might need more than that. Another thing that's really important, this is really important with COVID, is make sure you're breathing deep. So we have these little mouthpieces that you put in your mouth, a tube on it, and you blow real hard and you try to get the ball up to a certain level. That's all designed to expand your lungs. If you think about it, you're laying in bed all day because, I'm sick, I'm trying to recover. Well, you're not that sick unless you're unless you are that sick. But you need to get up and move because you're going to get weaker. And if you don't get up and walk and breathe deep, those lungs will be those little air pockets. Some of them collapse and they get fluid in them, and then the bacteria just love that. Hospitals are not the cleanest places. There's super bugs in the hospital. So you want to get in and out of the hospital as soon as you can, but use that incentives barometer. Get up and move, and finally, be kind to the people taking care of you.
Yeah.
You know, if you treat them well and you appreciate their efforts, they're gonna. I'm not going to say make more of an effort to take care of you, but they're going to remember how you've treated them, and they're going to be extra kind to you, extra loving. They're going to come in and fluff your pillow and, massage your legs, whatever. So just understand that there's a lot going on in a hospital. There's a lot of moving parts. And when you're laying there thinking, I'm not getting my pain medicine or I'm not getting that, it's not because we're ignoring you. And in today's environment, it's almost like the airline industry. Everything's overbooked in the airlines, right?
Mm-hmm.
It's the same thing in hospitals. We're so understaffed with nursing. There's a nursing shortage. We're understaffed with all the ancillaries. We don't have lab techs to draw blood. We don't have x-ray techs to be there. So it's a tough time. And COVID didn't make this any easier because a lot of people, they went where the money was, and these traveling nurses and these traveling techs, they can make a lot of money someplace else in a high acuity environment where there was a need. And now in many of the hospitals, there's just a shortage, and things are it's just like I was mentioning, going to fast food, a while back, you go and you wait forever and ever and ever. Like, where are the employees? And we have the same problems in hospitals. So the people that are there taking care of you, they deserve kudos. They deserve praise. They deserve thanks for sticking it out and doing the best they can in a difficult environment.
Thanks for running us through there. Thank you for being here. Thanks for sharing. Is that enough?
That's good. Yeah. That's good.
We do appreciate it. Dr. Tim McKnight this morning on our Talk with the Doc.